thank you very much to all the organizers. Happy to be here. And so I'd like to talk today about the use of neurostimulation to treat headache in the Chiari population. So in terms of my disclosures, I do consult for a number of device companies that manufacture the devices. Good? I'm good? I got the microphone. Okay, good. And this indication, called peripheral neuromodulation or neurostimulation, is a technique which is actually not approved by the FDA, so that is what's technically called an off-label indication. And I'll talk about that a little bit more. So I love the history of this condition, neurostimulation. This is actually the Roman Emperor Claudius. Now, why am I mentioning him? Because he lived in the early turn of the first millennium. He was the Roman emperor, and when he invaded and annexed Britain, in his entourage was a physician who was called Scribonius Largus. Now, he is the first physician who actually recognized that electricity can be used to treat a variety of neurological conditions. Interestingly, and particularly applicable to our discussion, is that the two conditions he mentioned, one of them is actually headaches. The other one was gout. And this is a picture from a textbook. What they would do was actually use a fish, much like an electric eel, which is called a torpedo fish. And they would actually put someone in a pool of water where the fish was in, and the electrical stimulation appeared to treat, at least temporarily, the symptoms of either headaches or gout associated with this patient. Now, I like to give this talk a lot of times. Let's see where our pointer is. Let's see, pointing right here. There we go. So the two people on either side of the patient were the original reps who worked for the device companies. So, you know, wherever I'm giving a talk, I usually mention a company. Anyway, so again, this is actually, 2,000 years ago, it was recognized that some types of headaches can be treated with electrical stimulation. Then if you move forward, that was Scribonius Largus, and then as electricity became, let's say, invented or common and so on with Benjamin Franklin and so on and so forth, there was a physician in Italy, Bologna, perhaps that's related to Dr. Bolognese anyway. So he applied a conductor. He took a battery and actually shocked the scalp of the subject, and he wrote, it seems highly probable that electrical stimulations may have in the future important therapeutic implications, a very prescient observation. And Frisch and Hitzig were a pair of German neurosurgeons who then proceeded to the next phase of neuroscience and actually exposed the brain of a dog and were able to map the brain, which is now commonly done in neurosurgery. Now, as the years progressed and electricity was more available, this is the early part of the 20th century. This, if you look at it, the Statue of Liberty holding a device called the electrete. Now, what this is actually very similar to nowadays is what we call a TENS unit, T-E-N-S, transcutaneous electrical stimulation. And they marketed it as a device which could cure a whole host of conditions. Obviously, in those days, the truth in advertising laws are probably not as strict, but in the earlier part of the 20th century, they mentioned a whole load of different conditions that it could treat. And then, of course, we've hopefully become a little bit more scientific. Now, when we specifically discuss the use of stimulation to treat headaches or facial pain, the history is really now 50 years old or older. White and Sweet, who were the first to publish something called the gate control theory of pain, which we'll discuss, they actually tried or exercised this theory on a number of people, and one of the first patients had what's called an infraorbital nerve stimulator, where the electrode is placed under the skin, stimulating one of the nerves in the face, and the patient reported an improvement in his or her chronic pain. What is commonly done today, called occipital stimulation, which is the most common location, was actually first called that by Dr. Weiner, who's a neurosurgeon from Texas, about 20 years ago, and he treated what he called occipital neuralgia, and then a lot of his cases were reviewed by Peter Goadsby, who was a well-known headache neurologist, and said, in fact, most of those patients had a condition called transformed migraine. But that was the first series of using these devices specifically for a patient with, let's call, occipital pain. And if you now do a literature search, there are hundreds of cases reported of the use of neurostimulators to treat a variety of headache and facial pain syndromes. So, again, now, when you step back a little bit, or going back in time, people actually were more invasive. They tried stimulation of the brain, so-called thalamic stimulation, in the 60s and 70s. Stimulation of the brain, obviously, is a more invasive procedure. I do it routinely, something called deep brain stimulation, to treat other conditions like Parkinson's disease, tremors, Tourette syndrome, and so on. So that was done actually, so the more difficult interventions were done before the easier interventions or safer interventions. So now, why did Weiner first start doing it? Because they had some animal studies that showed that if you stimulate the greater occipital nerves, which are the nerves on the back of your head, in animals, you could notice that a part of the brain called the trigeminal nucleus caudalis, we'll talk about that in a minute, had increased activity. So now, what does that mean? Let's go over a little bit of anatomy. I will try not to be too technical, right? So we all have these nerves called the occipital nerves. They're called the greater and lesser. There's also a third occipital nerve. So they arise from what are known as the nerve roots in the back of your spine. So the cervical nerve roots are numbered down from C1 down to C8. We have nerve roots up and down our body. And then they come together in a plexus or a branching or a sort of a grand central station. Each one combines, and they form a variety of peripheral nerves, right? As opposed to cranial nerves. These are peripheral nerves. So they branch out and form a number of nerves, including the greater and lesser occipital nerves, which run up the back of our head, and they provide sensation to the back of our head. Now, how does this work? Now, when we have headaches, on the other hand, most people believe that the pain transmission for headaches actually comes from different nerves, the trigeminal nerves, or the branches of the trigeminal nerve, which are the major cranial nerve coming out of the brainstem. So what is the connection between nerves in the back of your head and the trigeminal nerve? Well, the connection appears to be in a central gating location. So let's talk a minute about the gate control theory. So two scientists back in the 1960s, Melzick and Wall, decided that the method of pain transmission appears to be modulated, so by a gate in the spinal cord, and we'll talk about it a little bit later, up in the brainstem. So what happens is when you think about it, if you take your hand and you slam the door on your thumb, we'll get pain in our thumb, right? So what we'll do naturally and reflexively is we'll rub our thumb. That's what happens. We don't even think about it. Why are we doing that? So the general thought is that we are replacing one type of transmission of sensation with another type of transmission. So we're replacing a more comfortable or pleasant sensation for the pain sensation. That's called the gate control. And there's a gate, and it only lets one type of pain, one type of sensation or transmission come in. So first you have the pain going up, and then the gate closes, and now you have the other transmission. So let's move from, so that's the premise of what is known as spinal cord stimulation to treat pain in the arms and legs. What about in the head and neck and face? Well, there's something called the TCC, the trigemino-cervical complex. And as I mentioned, it combines inputs from the trigeminal nerve and the cervical nerve roots. And this is in a part of the brainstem. In the brain, what's called the medullary dorsal horn, it goes down into the cervical spine. And you have converging neurons. So you're having messages coming in from multiple places at all times. So the idea is, well, maybe if we change the electrical activity in this sort of grand central station area, using a New York analogy, we can then modulate some of the pain. And that is the thought. And that is one of the theories, for example, why Botox works for migraines. So if you heard Dr. Duarte speak earlier today, you're injecting Botox posteriorly. Why will that work for migraine? This is one of the theories. So we are now exhibiting exquisite control of this central area in our brainstem, the trigeminal cervical complex, and we're able to then, by doing things such as stimulation, we can treat other types of conditions, including headaches. So to go over the procedure itself, so the stimulation that I do, called occipital nerve stimulation, is a surgery. When you compare it to the other surgeries that are done for Chiari malformations, this is really, if those are graded, let's say, on levels of complexity, with 10 being the most complex surgery, anywhere from 6, 7, 8, 9, 10, this is really a 1 or 2. It's a very safe surgery. You don't go inside the brain. You don't even go inside the spinal cord. You just go under the skin, because that's where the nerves are. So overall, it is extremely safe. So how do we do it? Well, first of all, we'll talk about the hardware. What this involves is an implant into your body, and when I speak to patients about this, it's a little bit scary, but we think about the fact that nowadays people have pacemakers for their heart, they have artificial knees, they have artificial hips. It is a very common thing nowadays, and it is the future for a variety of conditions, and it involves two components. One are the electrodes. They're very thin. Each one of them is just about 1 millimeter in diameter, and a variety of different devices which we call the batteries, the pacemakers, or the generators. I showed 3 of them and blocked out their names from different companies. We now have in the United States probably 6 or 7 different companies that we can use, and depending on which is most appropriate, readily available. So what do? Well, the first thing we do before we put this in your body, in someone's body, is you do what's called a trial. A trial is very easy to do. You put 1 or 2 wires under the skin and you tape them to the skin, and the person goes home with them. So the way you do it is you put a needle under the skin, you put a wire through the needle and take it out, you put 1 or 2 of them, and we do what's called a trial. You go home, you try it out, we give you a little controller device, and over the next week to 10 days, people try it out and see how it affects their pain. To do the procedure itself, it's really 2 needle sticks. It's not particularly painful for the procedure. I do them in an operating room, so you can actually do the trial in a specific doctor's office with an x-ray machine. It takes about 10 minutes to put the wires in. And a couple of things to think about when I do it, for a variety of conditions. If patients have headaches that wax and wane, such as migraine and menstrual cycle, we'll try to time the procedure when they're at their worst. Cluster headache, which is also mentioned, sometimes it takes a few days for efficacy. And then the other important question, which I will discuss later, is where are the headaches? The largest body of literature talks about headaches in the back of the head, called occipital. However, this can be effective as well for pain in the front. If you only have pain in the front, you can put the wires under the skin here. For most people, the wires in the back are the appropriate way to go. And this is the example. So you see 2 electrodes being placed, and they're covering, so they're going across the branches. So imagine you have branches of a tree, and you're crossing all the branches, so you can control stimulation up all of those branches. And that's the trial. So this is an example of the procedure in 1 second. So as I said, percutaneous just means through a needle. Depending on the surgery, if this is more geared towards the surgeons, there are different ways to do it. The patient can lie on their back, they can lie on their stomach, and it all depends on a number of things. So patients, such as a Chiari patient has a fusion and they can't turn their neck, I'll put them in the most comfortable position for him or her to do the procedure. And it may depend on what you've had done before. A lot of the patients with Chiari that I see have already had surgery and they still have headaches. That's why they're referred for this procedure. So here's an example of a patient where I had them prone, their faces, they're lying face down. Interestingly, you can see that they have old scars there. This patient had already had occipital neurectomies. Another surgeon actually cut out the nerves in the back of their head to try to relieve their pain. Did it work? Well, she came to see me, so by definition, it didn't really work. There is some data that cutting out those nerves can help for a period of time. And our bodies, for better or for worse, regrow. The nerves regrow. So in some people, right, having nerve regrowth is good. It'll help you recover after an injury. In cases of chronic pain, regrowth or neuroplasticity may be a bad thing. So here, on an x-ray, you can see the electrodes here. This is a case just to show you, and I spoke about, if someone's already had surgery, you see these 2. These are OC fusion rods. So these were placed by Dr. Bolognese for another patient. And so in those cases, I don't send the wires across the rods. I don't want to cause any problems with the skin or the hardware because there may not be enough room for them under the skin, and you don't want them to pop out of the skin. So, and they're different. If you read different people's techniques, there are many ways to do this. And you have to sort of tailor it depending on the patient. So here, there are 4 different patients, and you have no hardware, standard horizontal electrodes. Again, it doesn't make the procedure any longer or shorter. It just makes it easier for the patient. You can put the wires across depending on where the plates are, same type of thing, or you can go to the sides of them or vertically. So that's a specific way to think about it in this population of the Chiari patients. So In terms of so now, patient goes home, all they have are some wires taped to their neck, and they come back to the office in about 7 to 10 days. Having done hundreds of them already, what I tell patients is the following. If you come back to me in a week and you're not sure it's working, then it's not working, period. The vast majority of patients know by day 4 or 5 whether it's helping, and if you're not sure, it really means it's not helping, unfortunately. And then we just take them out. It's like taking out an IV catheter. It takes 2 minutes, and well, at least we tried. Now, what happens if it does work? So then, if it really made a difference in someone's life, and there are ways to quantify that, they return either a few days later, a few weeks later, to have the device completely implanted. That's done under general anesthesia, and then you put new leads in. You have to make a number of couple, so the wires will go down the back of your head and under the skin. Everything is inside the surgery, no matter how you do it. It takes about an hour. It's not associated with a lot of pain, and people go home the same day. It's an outpatient procedure. So the device now is implanted, and they can start using it immediately. So to go over, what are the outcomes? Does this work? How well does it work? For who does it work? For who does it not work? Would someone be an appropriate candidate? Well, you look at the worldwide data, and the largest body of data is not for patients with Chiari, but it's really for migraine headache. That's just the way it is. We'll transfer some of the information, but when you look at it, migraine headache, there have been multiple what's called randomized clinical trials. And what they have done is they've implanted the patients with a device, and a number of them get stimulation, a number of people get what's called sham stimulation or placebo stimulation. So what does that mean? What is a placebo stimulant? It means that they get tiny pulses that don't really affect any nerves, whereas the active group gets stimulation at amplitudes and strengths that should be affecting the nerves. How do we know? We're not sure. It can be difficult to do a true randomized control, but it's been done 3 or 4 times. And what you want to look at really is improvement in pain. So most physicians who do chronic pain management look at a reduction in the VAS, the visual analog score scale. So if my pain is usually an 8 out of 10, if it goes down to a 4 out of 10, then it's 50%. That has been the most commonly used indicator. It may not be the best for headache. For headaches, other things may be important, really, medications, how many days they have headache a month, and so on. But this is the most commonly one used. And of course, you also want to look at, as I mentioned, the secondary variables and the outcomes, really. Significant. So those are the things we're looking at. And this is the result of one of the larger studies that was done. We were a part of it both at North Shore and then at NYU. And what they found was the following, without reading the fine print. You did see a difference in pain relief between the people who actually had the stimulator in and not, in terms of percentage of pain relief in that, but it did not reach 50%. It was just about 40% and less. So that means that the people who had the stimulator on had a higher percentage of pain relief than the people who did not have the stimulator on and had the placebo stimulation. Now, unfortunately, the way it works in the United States is that the FDA designs what's called a primary endpoint. They said the primary endpoint of this study, to say if it quote unquote works or not, is 50% pain relief. However, over the past few years, people in the field of pain management realize that in fact clinical significance is probably on the order of 30 to 40%. So this study didn't meet what's called its primary endpoint. It didn't meet its primary endpoint, which is 50%. It met it at about 30%. On the other hand, when you speak about conditions of headaches and treatments, when you look at Botox for migraines, for example, that's FDA approved. It met all the same criteria better than that one. So reduction in headache days, reduction in medication, and so on, and the MIDAS scores, without going into details, greater reduction in the number of headache days, and the amount of medications, and overall quality of life. So the FDA-approved treatment for migraine headaches, for example, is Botox therapy, and I know that there are a lot of patients with Chiari who also have Botox injections. Right, so that is approved. The stimulators have met all the same benchmarks as that, as the Botox as well, and actually better. So their results are actually better. So that's really the background of what we know about this for another condition, migraine headache. So I went to look, so I looked at my own data in terms of headache conditions, and this is published with one of my former fellows who now works in UMD&J Newark, Tony Mamis, and I categorized all the patients, our first 100 patients who had these stimulators placed for what type of headache conditions. And I try to categorize them by what's called the IHCD diagnosis, right? And whoever heard Dr. Duarte speak, there are different particular classifications. What schemes, how do we classify? How do neurologists and physicians classify headaches? And can that tell us something about predicting whether this will help or not? So in my surgical experience at that time, the largest group I had was Chiari malformations, and that is specifically due to the fact that I was affiliated with North Shore Hospital when the Chiari Institute was there, so Doctors Bolognese and Millerad and so on. So I have sort of a unique referral pattern, and that's why I'm here, and that I have a fairly large experience on doing this specifically for patients with Chiari, with the second most being migraine headache. That's the most common around. What are other things, in case you're interested? People can have post-traumatic headaches, occipital neuralgia. That's a particular condition where one of the nerves is pinched and you have shocks going up the occipital nerve. After cluster headache, trigeminal neuralgia, other types of things, hemicrania continuous. So these are a variety of headache syndromes, with my largest experience being that of Chiari. And then you look at the numbers. So what does it mean? So patients show up in the office and you say, okay, let's do the test or the trial. How many of them are successful, and how many of them say, wow, doctor, this really helped me. Let's go ahead and put it in my body. And then of those people that you put it in, how many of them down the road continue to report success? So in terms of Chiari, and I'll go into this in a little bit more detail in a minute or two, 18 of the 28 people, right, said to me, this worked, 10 did not. And then of those 18 people that we implanted, 15 at this last follow-up, which is about 2 years from that paper, 15 of the patients said, wow, this is making a difference in my life. And the other 3 said, doctor, I thought it helped me initially, and it no longer helps. The numbers are actually a little bit higher for migraine. And if you look at the other conditions, so interestingly, don't want to be a downer, but the success rate for Chiari headaches is a little bit lower than the general population that I see for headaches. Why is that? Well, multiple factors, I'm sure. As we've already heard, headaches in patients with Chiari malformation can be of a variety of different etiologies. It can be post-surgical, they can be migraine, they can be so many different things. So I think we're still not exactly sure of which are the patients to select. So in terms of the surgery itself, we are balancing, like anything else, the benefits and the risks. So what things can go wrong, right? So the general answer is anything that can go wrong with a stimulator is very easy to fix and will not result in any permanent problems. As I said, it's a procedure done under your skin. It is not a procedure done into your nervous system, into your central nervous system. So here's an example of a patient who actually had 4 electrodes, and one of them slipped a few months later into her neck under the skin. And how did we know that? Because she said, you know, the stimulation is not helping the back side of my left head, but it's still helping my right and my front on both sides. So we fixed it. We just moved it back up. It was another surgery, but we had that in our series of 5% of patients that were implanted. That can happen. And as the equipment has gotten better and better, the incidence and the techniques have gotten better. We've learned a lot over the past 10 or 15 years. The risk of this, or the chance of this happening, is low. Again, you would know that because it would be working and then you'd feel something different. What else can happen? Small chance of an infection or a skin infection. And what does that mean? Well, patients have a little bit of redness or a fever. Anytime you implant a device in your body, it can happen. You can have an infection. If it is a significant infection, the only way to treat it is to take it out. So that's a bummer if it's working, right? And then the patient has an infection. You have to take it out for about 3 months and put it back in. On the other hand, if you do have an infection, it's usually what's called a surgical site infection, so it occurs in the first few months. So if it doesn't happen down the road, it's unlikely to happen. So it's something that if you get through your first, again, the risk is extremely low. It usually happens in the first few months after surgery, and it's very easy to treat. There's never been a case reported where taking it out didn't cure the infection, period. And you will give antibiotics, but again, that's a 4% chance. Now, what else? This is something else a little bit more worrisome called an erosion, but they are under the skin. And I've had, over the years, patients, I had one patient where the wire came out, they lost some weight. So what we do is, this is one patient who came to my office, to the back of his head, he said, I feel a little bump. And when I looked very closely, the skin was getting a little bit thin. And I said to him, listen, we can either do nothing or wait, but I'm worried that if the skin has a breakage in it, you could get an infection. So we went ahead and fixed it proactively. And that's the way we did it. Those little white things are tubes called a passer, a quick 10-minute procedure, and we were able to fix it. So as a surgeon who does this, you have to be aware of the nuances of the technique. And one thing that is an issue is that, as I mentioned, to use this device for headaches is not approved by the FDA. So what does that mean? Well, it means that we're using wires and electrodes that are made to be placed in your spine that aren't necessarily the best for your head. And eventually, hopefully, they'll make better ones. So you probably don't want to use round wires with a point at the end. But either way, as long as you understand this and you're on top of it, the management of complications is very straightforward. So now, moving on to our own series. So this is our data. Dr. Vadavello is, I think, next door. He's giving a talk in an hour. So he was a resident who worked with me. Now he's a fully trained pediatric neurosurgeon in Cincinnati. So we took, and of course Dr. Bolognese and Dr. Milharat worked together. We took just the Chiari patients and we looked over, reviewed all the data and looked at our outcomes. So just to look some of the numbers, these were our initial 23 patients. As you would expect, there's a predominance of females over males, with an age range ranging from age 14 to the 50s. Most of the people had pain on both sides of the back of their head. And as you would expect again, the comorbidities, the Ehlers-Danlos syndrome, the tethered cord, these are commonly seen in Chiari's. So remember, I'll emphasize that these are people who already had surgery for the most part. I think maybe one didn't. Most of these people have already had at least one surgery for Chiari malformation treatment, including something like a posterior fossa decompression, a fusion posteriorly, and so on, or both. And they came to us only because, even though the fusion was solid and everything was decompressed appropriately, there are a small number of people who still have debilitating headaches. So those are the people who I would see and recommend this technique. So as mentioned, we trialed, we proceeded, 22, 23 trialed, 15 went to implant in terms of long follow-up. The later follow-up, we see 12 out of the 15. So overall, what I tell people is the following. We'll do the trial. It may work or may not work. If it doesn't work, it doesn't work. We don't go ahead. If it works, there's a pretty good chance that you'll continue to use it. Not 100%. Nothing is 100% guaranteed. There's probably a 75% chance that this will continue to help you. So now, let's go over that. Again, let me see if I can actually read this. Yeah, so these were, this is just a review of the complications. We had 6 people who needed wound revisions or migrations. So complications, as I mentioned, it occurred in a number of patients. There was actually nothing that couldn't be treated very straightforwardly, lead migration, and one wound infection. So 6 of the patients did have it. And one thing you do see when you look around the world for neurostimulators is that overall, I tell patients, you're probably going to have, in your lifetime, there's probably a 15 to 20% you'll have something that I'll have to deal with the device. Something, but nothing major or worrisome. And this was what's called a downward migration in one of the patients. The lead slipped down in the back of her head. The vertical leads. Another example I showed you before, similarly. And this woman, if you see it, the electrodes are placed vertically. It's not the best way to do that because of gravity coming down as opposed to horizontally. But we had no choice because of her hardware in the back of her head. So now, what else to think about? So when you think about it specifically for Chiari patients, what about the location? You think about the location, right? So the literature, the worldwide literature talks a lot about occipital headaches in the back of your head. So we prefer, and I tell people the best data we have to predict it is really when your headaches are occipitally predominant. We're in the back of your head. Now, what if you also have patients that say, you know, doctor, I really do have a lot of headache in the back of my head, but now I'm also getting it somewhat in the front. So what do? You can actually add wires in the front as well. And this is an example of one of the patients that actually had 4 electrodes. This has been made easier and easier because over the last few years, the pacemaker devices used to only hold 2 wires at a time. Now they can hold 4 wires at a time. So, but it does involve more surgery, more incisions to put them under your forehead. If someone is thin, you can see the devices and they may be cosmetically unappealing, but it's just something to think about overall. And as the years have gone by, we've sort of segmented the patients into occipital, frontal, and so on. If someone only has frontal headaches, we would probably just place the electrodes in the front only. And okay, so we're already towards the conclusion, a little bit short of the other doctor. So let's think about it. So this is an option. The way to look at this technique, it is an option that is available. So in a subset of patients with Chiari or other conditions that they've had the appropriate treatment, and I think people in this audience will know whom to go to for the appropriate treatment, but yet the headache is their problem, this is a treatment. So the way to look at it, you know, again, people try medications, injections, and so on. This is something in the armamentarium available to treat the headache symptoms. We're not going to cure any underlying anatomical abnormality, but we can treat the headaches. It is a safe procedure. There are device-related complications that occur, but none of them will result in any adverse sequelae. So as I mentioned, so in patients who've had appropriate decompressions, fusions, or both remain disabled from severe headaches or pain, this is something to think about. As I said, in the United States, we do have an issue over the years, just practically, that the insurances, of course, are getting harder and harder to approve things. So when I started doing this with Dr. Bolognese about 10 or 11, 12 years ago, it was easier to get approval. Now, for the most part now, it takes a while. It can take 3, 4, 5 months, and sometimes they'll deny it. Those are the realities. But if you are persistent enough, and it's an appropriate patient, we usually are able to proceed and at least give the patients a shot at having some benefit. So thank you very much. And my last slide, where is my last slide there? I wanted to thank, of course, Dr. Bolognese, Dr. Millerat, Dr. Vadavello, who's speaking next door, and my nurse practitioner, Maria, who has been an integral part of my clinical practice for neuromodulation. Thanks a lot.
Very much. We got a couple of questions. One is how young of a patient might perhaps be the electrodes be implanted in? Okay. You mentioned a 14-year-old,
yes,
I think.
A 14-year-old. We actually, so one of the issues that can arise, there's no absolute lower age limit. In general, we are hesitant to do it in the pediatric population. In terms of the care, there are issues in terms of actually skin growth and acne and so on, and over the superficial wounds. We had one patient now with a Chiari, 12 years old, and as she went into adolescence, actually had an outbreak of acne over the electrodes. We had to take it out. So overall, you know, as I said, youngest has been 12 years old, but there's no absolute lower and appropriate patient. I think the best question really is this person really disabled? And do you want to treat them? You can think about this device actually. Some people have thought of it as a bridge therapy. In other words, if someone is so disabled by pain and they're a child or adolescent, you want to get them through that phase where they can at least go to school, be integrated socially, and maybe at a later time not need it. That's fine. It's extremely simple to remove the device.
Do you have any feeling about the TENS, which is external stimulation, really maybe affecting motor, maybe not sensory quite so much? This is somewhat different, but how would you compare those modalities? And does external stimulation like TENS work for some of the patients?
So people have tried it. It used to be thought that they needed to correlate, that if the TENS And in order to do this, the TENS would have to help for some time. I have found, and there's also a technical problem. So most people who have TENS units tape them on their back or so. And to keep them taped on the back of someone's head for a long time is functionally difficult to do. There are people who have used it, and it has helped them. I would only proceed to this. If that is benefiting them and they're using it enough, that's fine. The principle is more or less the same, right? Electrical stimulation delivered in one way, shape, or form, but if you're delivering it through the skin, it's harder to get to where you want to go. So I have had patients use it. Some have benefited, but I will also say I have a skewed population and that I have seen a lot of them where that has failed for a number of reasons. The advantage of this device is that it's on 24/7 continuously.
And how much control of the stimulation do the patients have? Do you have certain paradigms stimulation paradigms, and how long do the stimulators last? That I suppose depends a little bit on how frequent.
So patients do have control. The devices now are extremely fancy, and they're actually too fancy. How the patients can make it stronger or weaker, change different patterns. They can make it stronger on one side or the other side, and everyone sort of learns his or her best way to use it. There are some newer paradigms called burst stimulation or high frequency, which seem to be even better, where they, over the past few years, maybe even better. And the pacemaker devices themselves, depending which one you use, lasts anywhere from 3 to perhaps 15 or 20 years. The longer lasting ones are what's called rechargeable, which means once a week you'll have to wear a little patch on your chest or wherever you put it to charge it for 45 minutes. The ones that are not rechargeable will not last as long, but you don't have to maintain them. So we discuss it with the patients, and people say, listen, if I don't want to think about it at all, but I'll come back in 4 years for a 15-minute replacement, that's fine. But if someone says, I don't want to have another surgery for 15 or 20 years or whatever, and I'm willing to spend 45 minutes a week recharging, then we would use that. So.
Okay. Thanks very much, Alon.